Prakash. Thank you for kind introduction. And obviously, this is a very important area in critical care practice, that ICU scoring system. As Dr. Jayaprakash says, that there are a lot of scoring system, but few are you have to know in those who are practicing in the critical care. So, coming to the topic that why scoring system is important, because most of the time the family member is asking that, sir, how my patient is there and when the patient will be discharged from the ICU and what will be the prognosis. So for this type of question, when you will face, the answer is coming from your this predicted outcome by ICU scoring. So because it also there is a cost involved per day. Any standard ICU cost is around 70 to 1 lakhs rupees cost in a standard ICU care system. So if you can predict the mortality, if you can predict the length of stay, then you will have a good answer to communicate to your patient. And that's why you have to have some sort of scoring system to maintain the quality of care, to reduce the mortality and to reduce the cost, and also in an end of life care situation, you can predict early the mortality and you can communicate the patient family, so you can avoid lot of the litigation. So patient family wants the criticality of the patient and the outcome. So unless you doing the good predictive scoring, you will not able to tell them what will be the outcome. That's why I have kept the scoring system. Though there is a no direct question in the EDIC from the scoring system, only one scoring, the question come from the one scoring system, that is CPI, the pneumonia scoring system. But the rest of the scoring system, you will not face the direct question. But in your part 2 exam in IDCCM or in your DRNB or in your DM or in your part 2 EDIC part 2, when you will have a scenario like very critical patient in ICU multi-organ failure, they will ask how you will predict the mortality and how will you communicate with the patient family. Then they will ask about the scoring system. Okay. So the account for disproportionate large function healthcare resource, and also it help your resource management triaging, which patient you will give more time, more effort, use more resource, and which patient you will tell the patient family, do a we take the ceiling of care or end of life care consent. So this ICU scoring will help you. So today I will, there are a lot of scoring system we have, and we will discuss a few of them. So improve what it help, improve ICU performance, already told, improve quality of care and optimizing the cost. So factor have implied development various outcome. And why outcome? That help compare performance between center, and you can compare the one ICU to another ICU. You can improve your services. So component of the scoring data, previous and current health information, as well as physiological and the laboratory data. Score determine the outcome. The popular score as of now, we have a popular score: Apache, SAFS, MPM, SOFA. There are multiple regarding the hemodynamic, regarding the NIV. There are multiple score, but I do today I will not cover all the score, but remember that each score there are specific implication, but these four scores, that is Apache, SAPS, and the SOFA, these three you can use regularly to predict the mortality of the patient. You can prognosticate your patient. You can do better communication with the family. So you must know this score. And also when you will face the long case viva, you might ask this component of this scoring system, and how will it will help your day-to-day practice. So Apache, we know there are a lot of variation come Apache 1 through 4, but Apache 2 is more popular till date. And there are acute physiological and chronic health evaluation is Apache, and there are multiple component is there, and you need to have a very good software where you can put the data, and Apache will come. And nowadays it is available in the mobile also, so you can do. But it is first, I mean, Apache you have to do first 24 hours, then it will give your predicted mortality rate and the severity of the patient. So it will help your loss management. It is help your cost management, and also it help to what I say, this is counseling to patient family. So better discriminating power and disadvantage, less impressive calibration, and deteriorating performance over time due to changes. These things, number of input variable is high, and simplified acute physiological score, that is SAPS score. SAPS scoring is calculate severe scoring using the worst value measure within first 24 hours of the ICU admission. It's basically a simplified of the Apache, and score are entered into the mathematical formulation to predict hospital mortality, and they use the 20 variables. So it is also is not very easy to calculate, but you have to have either software or you have to have the app in your mobile. You can do, and there is a predicted mortality and morbidity. So advantage, data extraction easier when you compare to Apache, and it has ESAPS 3 version and generated potential for international use, since you can use in every country. And disadvantage, does not predict the ALOS, average length of stay, and mortality predictor model calculate from variable at the time of admission, except for age. All variation are dichotomous, and final score is entered into the mathematical formula whose solution predict mortality and low extraction burden. Disadvantage, does not predict the length of the stay. So this is the list of your variables. And advantage, lowest extraction burden, clinical and physiological data, no lab data required, but again, it does not give you the ALOS.